All right, I have broken things down into 5 basic organ segments. I know there are a lot of them. I told you 3 years I've been working on this. Okay, but I also put some icons in so that you can see some basic facts about every case. So 37 of the 50 cases we will look at are motor vehicle collisions, and that will be designated with that green triangle. The other causes, well, we have the typical guns and knives. Actually, that's not a knife, it's a screwdriver. We have a soccer mishap, and then we've got a bull, a horse, a doctor, and a woman. So those are the potential, the sources of these traumas. I also went to the National Center for Biometric Information and pulled the expected mortalities for every one of these injuries. So you'll see that with each one. And then whether or not the patient lived is certainly an item of interest. So a deceased patient will be designated with that ghoulish skull icon. And then whether the radiologist actually made the call or not. Did they see the finding? That'll be a red X if the radiologist missed the finding, like Miss Oathmar used to put on your grade school tests. So what this ends up is we have iconized all these things for every one of these entities, and you'll see those at the bottom of the screen. So if you ever think, hey, did this guy make it? You just look to the bottom and you'll be able to see the icon. So the first one here is a peritoneal laceration. And I always remember my first night on call in radiology, there was someone who came in with a laceration to his soft tissues, and the whole surgical team was standing over me saying, was the peritoneum violated? I mean, they were screaming. And I said, oh, I don't think so. They didn't find that helpful. So, you know, I am always taken back to that when I'm looking at this, though. You're looking for gas in the peritoneum. You're looking for fluid there. But incredibly, this patient had a laceration of his peritoneum. There's all this extensive soft tissue injury, fluid, gas, etc. But right there, the peritoneum was lacerated, and there's actually peritoneal fat extruding out through that gap. So this is not the typical way that you would diagnose violation of the peritoneal cavity, but there it is. So the other thing that's amazing here is that calcification. So this came to me through QA. So I opened this up, and this had been submitted as a QA, and the on-site physician had typed missed rib fracture. So this was immediately, and thank you, Ed, for this. Ed, your footprints are all over vRad, but Ed helped create our ICD-10 ordering module back in 2015. And we had just instituted it. And so techs could go through these serial pull-down menus and generate an ICD-10 compliant history that then was submitted to our radiologist. Well, this clinical history came in and it said, gored by bull. So our radiologist looked at this and said, well, there's violation of the peritoneum, and there is the tip of a bull's horn sitting in the soft tissues. And the doctor on site, when I called him and I said, this is clearly not a rib fracture, that's a tip of a bull's horn. And the guy said, oh, that's ridiculous. And I said, well, the history here says gored by bull. And the on-site physician says, where the hell did you get that? Mine says pain. And I thought, you know, we may be onto something here. But isn't that incredible? The tip of a bull's horn broke off in this guy. And so that's mostly manure you see in his soft tissues. So that is a dirty wound. But there it is, the tip of, you can see it's conical. All right, an adrenal venous laceration. This is an important thing to spot. A little bit of stranding around the adrenal can be a very important sign. Right? But always remember the two things that contribute to the risk of a vessel injury. The shorter a vessel is, the less it can stand shearing, right? And the thinner walled that a vessel is, the less it can stand trauma. Right? So of all the vessels in this region, the one most susceptible is that right suprarenal or adrenal vein. It is short and it is thin walled. And you can see right here, it's actually extravasating. It's avulsed most likely from the IVC right there. You can also see the adrenal is there in the gyrotous fascia with the right kidney. So it's a little bit outside, the hemorrhage is a little bit outside gyrotous fascia as well, but most of it is perirenal in the right perinephric space. So there you can see a little contrast around it. This is a very large adrenal hematoma. And again, these are important to spot when they're small because they can suggest significant injury, right? An indicator of abdominal injury that should force you to do a more thorough evaluation. And it's really nice on the coronals. You can actually see it distorting the superior aspect of the right kidney. Right? So that is an adrenal venous avulsion. And this one's just big. I've never seen this big a subcapsular hemorrhage before. The thing that I really like about this is there's this huge subcapsular collection, but that more lateral arrow is pointing to a spot where it's actually popped through the capsule and is bleeding intraperitoneally. And so that's a little more appreciable when we get to the cines, but you can see there's a great deal of intraperitoneal fluid, which should not be there if this were a contained subcapsular hemorrhage. So right there, you see it's actually on the outside of the capsule. And that's what's causing all the intraperitoneal hemorrhage that you see lower down here. Right there. So it's impressive too. You can see how the capsule was just ripped off the liver parenchyma, and it's all just hemorrhaging all along that interface, right, where the capsule's been elevated. I want to call this brush fire sign or something like that, because you can see all that basically raw and exposed liver parenchyma is hemorrhaging there. But it was interesting that you can see it popping just outside the capsule there. All right, this one was from the teaching file. Todd Lempert put this in, and he's coming for you, Jim Sloves. Oh, Sloves had to go. Todd Lempert is putting a lot of stuff in. He's one of our new radiologists, but he sees some crazy stuff, and this is a great one. This is an IVC laceration, so you can see the linear defect through the IVC. This was associated basically with a hepatic venous avulsion. And so there is a liver laceration going right up to the IVC, and these are the really dangerous ones. When you look at IVC lacerations and their mortality, the ones that people worry the most about are in the intrahepatic portion of the IVC, because obviously you can't get to that if you do decide that you need to operate on it. All right, and this patient is pretty hypotensive. Just thought I'd point out that tiny sliver of an IVC there. So on the cine, you can really appreciate that the hepatic vein is actually avulsed right below this level, right there. You can see the left and middle hepatic veins, but you don't see the right hepatic vein. And it's interesting, you'll see on some follow-ups here, there are significant perfusion changes in the right liver lobe. You can appreciate it right there, in fact. Right, so here, with a delayed, with those crazy perfusion changes, it's actually hyperdense. And there's no opacification of the right hepatic vein. Let that go one more time. All right, so with this patient, they did not operate again. And so this is the 1 week follow-up, maybe 10-day follow-up, but you can see now you're getting opacification of the right hepatic veins, that liver laceration is resolving, and that little pseudoaneurysm of the IVC is smoothed out. It looks like the left and middle hepatic veins were almost avulsed as well, right there. All right, so that is an IVC laceration of the intrahepatic portion of the IVC. You don't see many gallbladder lacerations, and you don't see any like this. All the gallbladder lacerations I have in my collection, I have a decompressed gallbladder with a defect in the wall, right? It's because as soon as you rupture your gallbladder, it just deflates. But this one Sean put in, and it's actual hemorrhage. So you can see the layering clot in this very distended gallbladder, but it's incredible. There is actually hemorrhage originating from the anterior wall, and it's just bleeding down a tiny channel through that blood-filled gallbladder. It's just a little dribble of contrast coming from that wall. Incredible. Well, they ultimately did take this out. I said, did you guys debate whether it had to come out? And they said, oh, no. You know, when we got in there, it was just huge, distended, and completely full of clot. It was never going to go away. So a very bizarre gallbladder hemorrhage there. All right, this is a subcapsular hemorrhage of the spleen. It's kind of similar to that duodenal hematoma that we saw before. This one's contained by the capsule. It just gives you a sense of just how much the capsule of the spleen can stretch. You can see the irregular lacerations there on the hilar aspect of the spleen. Look at that clot and that claw sign. On the coronals, it's just amazing. It extends all the way down into the pelvis. But it's for the most part contained. He definitely does have some peritoneal fluid, but look at the size of that. And you can really see the splenic laceration on the undersurface of the spleen there. All right, so that is a subcapsular splenic hematoma.